Good day, everybody. It's really a pleasure to welcome you, and on behalf of Professor Jean-Michel Pawlotsky, to our Best of Viral Hepatitis debrief coming from the International Liver Congress from the EASL organization. And we have prepared two short presentations showing you the highlights of the Congress, and we would like to start with Hepatitis B and then followed by Hepatitis C. So I would like to give you a brief overview what I've picked as best of chronic viral hepatitis B. And I would like to briefly show you new treatment options we have seen in phase 3 clinical trials, but also early clinical and preclinical phases. There's interest in the long-term nucleotide treatment and potential risk factors with respect to the development of early cancer, and this was a question. And the long-term effect of PEG interferon were evaluated, and we have new data on predicting treatment response. As you probably know, there's a lot of interest in the add-on strategy in patients being virally suppressed to add PEG interferon, and we have the first prospective and randomized trials showed at the Congress. And if we have time, I will briefly mention Hepatitis Delta at the end. So let me start with the new treatment options for hepatitis B. And we have seen two large phase 3 trials evaluating a new tenofovir, a tenofovir prodrug. It's called the tenofovir alafenamide. And this was studied in two large trials, phase 3 trials in E-positive and E-negative patients. And this in data here I would like to show you from the phase 2 trial evaluating TAF in comparison to TDF. And the rationale for using TAF instead of TDF is that the new tenofovir prodrug has a greater plasma stability than tenofovir. So it will enhance the delivery of the active drug by also reduced circulating levels of tenofovir relative to TDF. And it's hoped that due to the lower levels, as you can see here, there might be also an improved safety profile regarding bone and the renal safety. So what had been shown with respect to the primary endpoint, and this is complete viral suppression, HBV DNA below 29 international unit, and you can see here that TAF and tenofovir were equally effective with very high rates of complete response in the E-negative patients and around 64 to 67% complete response after 1 year of treatment in the E-positive patients. There was an interesting finding, and I also discussed with Jean-Michel, but we do not have a good idea why this happened, that the percentage of patients who normalized the ALT was a little bit higher with a new compound, and this was significant if you have seen more stringent laboratory criteria for normal ALT coming from the EASL, as you can see here, 50% normalized with a more stringent criteria as compared to 32% with a TDF compound. So Jean-Michel, do you have any good explanation why this happened?
No, I don't have any explanation. The tenofovir is tenofovir. I mean, this is the same drug, but it's a different mode of delivery. So one is expected to have a higher concentration in the liver with lower circulating concentration, and we see it translate with slightly less side effects, although tenofovir is relatively well tolerated anyway. So it will be an incremental improvement in long-term safety. This ALT, I've no idea, and this has been discussed during the conference, and nobody really understands these results.
Yeah. At the end, if it holds true and it has something to do with minimal inflammation, it might make a difference also in the long run. We will see.
It does not translate into differences, apparently differences in the HBV DNA kinetics. Yeah. So there's a specific effect, it's hard to say.
You know, TAF was developed in order to improve safety of tenofovir, and I think the data nevertheless clearly shows that tenofovir TDF is a safe drug. But if you look quite closely, you can see some minor differences. First of all, with respect to the spine bone mineral density, you see that with TDF, there is in the beginning a more pronounced decline, but later on it stabilized. But this wasn't seen with a TAF compound. And quite similar for the renal safety, the eGFR, you see a minus 4.7 decline in the eGFR as compared to minus 0.3. So at the end, I think not a big difference, but for some patients, especially also for co-infected patients where probably renal safety is a bigger issue, I think clearly it improves safety of the drug.
Maybe we have to mention that this is arriving at a time when tenofovir is becoming generic, and TAF is slightly better tolerated, but tenofovir has been used broadly over the world, and I think for countries that will have access to generic tenofovir, it's a perfectly safe drug that can be used very confidently in HBV patients.
I think this is clearly confirmed by these data showing only minimal changes in the bone safety and renal safety. So now I would like to move more to the experimental developments in chronic hepatitis B virus infection. This has all to do with our aim to cure hepatitis B virus infection in the future, have new compounds that we are able to eradicate HBV infection from the infected cells. And there's a big interest in a new class of inhibitors, and these are core or capsid assembly inhibitors, and they were mainly studied preclinically, but also one study in phase 1b in human. Very interesting substances are also the small interference RNA molecules, and here we have chimp data and also data in human with a phase 2a. And at the end, we have seen some data with the entry inhibitor, the Mercledex B compound. And here also pharmacokinetics of the Mercledex B were evaluated together with tenofovir. And as you know, the entry receptor for hepatitis B is also a bile acid receptor. So it was nicely shown in this study that in a dose-dependent fashion, you may inhibit this receptor and you may have an increase in the bile acids. But it was clearly shown that it's nevertheless very safe and you can safely use it together with tenofovir, which can be important. And this drug is now in phase 2 in patients with hepatitis B and hepatitis Delta. But let's move forward to the core or capsid inhibitors. And you see here the HBV life cycle, and what these inhibitors do is they inhibit the encapsulation of the pregenomic RNA, and this is a quite important step in the replication of the hepatitis B virus. There are several compounds under investigation, and they are all listed here. Highlighted in blue are those substances where we have seen data at the ILC, and probably I would like to highlight the one NVR3778 core inhibitor where we have seen early phase 1b clinical data in human, and it has been shown that with this core inhibitor you may reduce HBV DNA by approximately 1.7 log, and if you add PEG interferon, this is slightly increased. Interestingly, we haven't seen S-antigen decline in this clinical study. In the preclinical models, these substances were also highly active. So what do you expect? It's just too short, a single dose, not effective enough. But at the end, we would expect also a decline in S-antigen.
Yeah, it's difficult to say. There were, as you said, many new drugs presented, many new concepts for hepatitis B virus infection. My impression is that the endpoints are not very well defined. There are mechanisms. Will this contribute to inhibiting the viral life cycle? Will this have an effect on the cccDNA content? Will this decrease HBsAg? I think we have to understand more the mechanisms, but also these studies have to be better designed with the appropriate groups of patients and the appropriate endpoints. So this is very preliminary data. What I've taken from this specific compound is that it can reduce viral replication overall, the block partly the life cycle, but we need more and we need combination therapy. And at the end, I think we have good drugs that block viral replication already with a high barrier to resistance. So the real question is being able to reduce the HBsAg levels and eventually lead to a functional cure of HBV infection. And we're not yet there.
Yeah. I think it's interesting to see that these are small molecules, probably quite safe, but It's also interesting to see that within this phase 1b study, there was one patient developed a kind of a rash or hand-foot syndrome.
You never know what will be safe or not, and you need large numbers. Yeah.
So let me move forward to the small interference RNA molecules. And these are, as I mentioned, studied here at the ILC in chimps, but also from the phase 2a clinical data were presented. And the concept is here that with these small interference RNA, you will block the pregenomics, the mRNA of hepatitis B virus, and herewith you have, or hereby you have reduced viral protein production. So it's believed that if you reduce the viral antigens, this may be associated with a restoration of the immune system. And what we have seen was interesting. Again, short treatment, but a significant decline in HBs antigen was shown with a maximum reduction of about 1.8 log. But this was especially seen in the E-positive patients. And the explanation is that in E-positive patients, the S production mainly comes from the transcription from the cccDNA and pregenomic RNA, whereas in the E-negative patients, this effect was not seen, and this was explained that it's more a transcription from integrated HBV DNA. So it's very interesting, and we learn a lot about the biology, the molecular biology of the hepatitis B by evaluating these new drugs. So it's in a way very fascinating.
Yeah, it's very fascinating, very interesting. RNA interference has been tried in many diseases without much success so far. I think this data shows that there is an effect. It has to be very well targeted, because you may, if you start playing with genes in the cells, it may have consequences. If it's very specific for cccDNA and induces any kind of functional blockade, it may work. There is RNA interference. We also have CRISPR-Cas9 right now, which is another approach to block genes in cells, which could be interesting. So we'll see what happens, but this looks promising.
Yeah. Okay, I will now come more to clinical findings, and these are the long-term consequences of Nook treatment. And the rationale behind this study is that in the preclinical models, some of the Nook we are now using for our patients were associated in mice and also in rats with the development of adenoma and some cancers. So the authors here from Hong Kong asked whether there is any increased risk of malignancy seen in patients being on long-term Nook treatment. And this is really a very large population-based study with, you see here the number, more than 4,500 patients included and a large untreated cohort. And I only would like to show you the conclusion of this large-scale population-based study. And I think the data are quite clear that there's no risk, increased risk of various malignancies in Nook-treated patients in the long run. But there was a special attention and a small signal I think we have to keep our eye on, that in female patients receiving long-term Nooks, there seemed to be an increased risk of colorectal or cervical cancer. The authors were not clear whether there's any bias they couldn't cope with, but I think this may stimulate further studies to see whether we can prove or disprove this finding.
It's always very difficult to know whether there were confounding factors or not, but you must probably keep an eye on this.
Yeah. I think the main message these substances are saying with respect to malignancy.
Yeah. They've been given to so many patients already.
Yeah. PEG interferon alpha is not so widely used anymore for the treatment of chronic hepatitis B, but many people are still interested for this type of finite treatment. And the question here was, how sustained is sustained response when you have treated a patient for 1 year? And I have selected this study because it's really a huge collaborative work, and it's a prospective global observational study. It's called the ESCalate study, and there were more than 1,200 patients included with E-positive and E-negative disease. And what you see here is the end of treatment response and the response in the follow-up without treatment after 3 years. You have to keep in mind that the denominator is declining, so you have to interpret the data on a declining number of patients included, but more or less, you can say that the response remains stable after stopping treatment, and this has been shown for E-positive and E-negative patients. But at the end, if you look at the combined response or endpoint for the E-negatives, this means ALT normalization and low HBV DNA, the numbers are around 25–30%. And what is probably a little bit disappointing if you look at the S clearance rate, because it's believed that with interferon you may induce a significant number of clearance. So even for the E-positive patients, when you look at an intention to treat analysis, only 2% lost S, and for the E-negative, only 5%. Well, yeah. I think that's a reality.
The reality that's disappointing. Interferon has been the only compound that convincingly showed reduction of cccDNA in vitro, so we have high expectations for interferon. The real life tells us that clearing HBsAg is not an easy thing.
Yeah. So I think for interferon, it's very important to have good predictors who is going to respond to select the right patients. And here I think we have interesting data from different groups, and many groups of them had the feeling that it's important also to take the hepatitis B virus genotype into consideration, and the response rate is better in patients with hepatitis B type B as compared to C. The other predictors as listed here are more or less those predictors we already know, so people will respond better if they have a younger age, if they are female, if they have very high ALT levels, low HBs antigen or DNA levels. But you can see with these different scores, I would like to mention, not to mention too much into detail, but you can predict response rates in the rate of 0 to 15% if the score is low, up to 60 or 40% if you have a high score. So in a way, I think it might be helpful if you select.
It's not a very strong predictive value, though.
Yeah. So while we're waiting for new compounds, we try to deal with what we have in order to improve response rate, especially the S loss and the cure, the functional cure of hepatitis B virus infection. There's a lot of interest in adding PEG interferon in those patients being virally suppressed. And here we have very interesting data because they are prospective and also one randomized trial evaluating this concept. For the randomized trial, we have week 24 interim analysis, and for the prospective single-arm study, long-term results. So what have been observed in a randomized fashion? And you see if you start interferon, and here the S antigen levels are depicted in patients being virally suppressed, it takes some time until you see something, but then there is a more pronounced decline in S antigen levels as compared to the Nook, but in both groups you see an S antigen decline. The authors had a cutoff of 10% reduction as an effectiveness measure, and you see here that a decline of more than 10% after 24 weeks of treatment was achieved in the Nook treated with nearly 40% and more than 70% if you have a PEG add-on. From the Lampatico trial, again, adding PEG interferon lead to a more pronounced decline in HBs antigen level, but if you stop interferon and only the patients with a decline were followed, then it remains relatively stable in the long run, and the S loss rate was only 2%. However, some patients at this stage had very low S levels, and we will see what will happen then. So I think I would like to conclude with a brief words to the Delta hepatitis. Most difficult to treat. We only have interferon. Nooks do not have really a significant effect. And the colleagues from Hanover tried to analyze what is the long-term effect of this interferon treatment. And to make a long story short, overall they convinced us, and I think this is in line with what we have seen in previous study, that interferon has some long-term benefit with respect to clinical endpoints, but still many patients will progress with more advanced disease. So we need new treatments, and during the ILC we have seen some new data on inhibition of prenylation, which is important for hepatitis delta replication. And it's interesting to see, and this is now in phase 3, the lonafrenib substance in its ritonavir boosted, that you can see a nice decline in delta RNA under this treatment. And quite interestingly, if you block replication of delta, you may see that there's an increase of B replication. So what we already know, but this is now really confirmed by these trials, that delta inhibits B replication. So more or less, this is what I would like to tell you.
Delta has been frustrating forever.
Yes.
Heino Wiedemeyer started this meeting on Wednesday morning saying the only drug we have that works on delta is interferon, which was a bit frustrating. So there is a little bit of hope on this side.
Yeah, yeah. Also, the safety might be an issue. There are some gastrointestinal toxicity seen. Therefore, to reduce the dose, ritonavir was added. So it's very interesting, and it's the first substance where we clearly see an antiviral effect. And of course, we will see what the entry inhibitor, Merclodex B, will do in this patient population.
Good work on this as well, yes.
Yeah. So I will hand over to Jean-Michel. Thank you very much.
The second part of our debrief will be on hepatitis C virus infection, and I will split it into 4 different parts based on the data that has been presented at the International Liver Congress. Real-world data, we had a lot. Special populations, some are really interesting and challenging. HCV resistance and treatment failures, and we'll finish with the new treatments, the new generation of HCV drugs that are coming. So to start with the real-world data, there were many studies showing real-world data from several European countries and from the United States. All types of interferon-free therapies were used, including sofosbuvir-based therapies, sofosbuvir-ribavirin, sofosbuvir-ledipasvir, sofosbuvir plus cimeprevir, sofosbuvir plus declatazvir, and also the non-sofosbuvir containing 3D regimen with ombitazvir, paritaprevir, ritonavir, plus dasabuvir. Different groups of patients, and if we try to summarize in a few sentences what has been shown in these studies, number one, they confirm efficacy of interferon-free regimens with SVR rates that were very close to those reported in clinical trials. They also confirmed the global safety of the interferon-free regimen. There were no major side effects that appeared that were not seen in the clinical trials. However, if I may have a word of caution, we should not use the result of real-world studies to compare different treatment regimen efficacies because the patients were not randomized. And I think the weakness of these real-world studies is that this is at the doctor's discretion. The doctor prescribes the treatment, and it generally has a good reason to do so. Therefore, we have to be very careful and use them only for validation of global overall efficacy and overall safety. And I have chosen 2 examples that, Thomas, you may be willing to comment. The first one is a German hepatitis registry where a large number of patients have been analyzed from the real world. And what you can see here is that the SVR rates were very high for the sofosbuvir-declatazvir combination, 95% SVR rate, very high for sofosbuvir-ledipasvir, 94%, very high for the 3D combination, 94%. They were slightly lower for sofosbuvir-cimeprevir, 86%, also lower, but that was expected for peginterferon, ribavirin, sofosbuvir, 84%. So how do you explain this lower rate of SVR of cimeprevir, sofosbuvir compared to the others? It was not apparent in the clinical trials.
Yeah, I think as you mentioned, we should not really compare this from the real-world data because there are no randomized patients. It could be also that some of these patients, because we had early access to this type of compound, that more difficult to treat patients were included initially, and some of them also with a problem of resistant-associated variants. So I think we cannot really deal with that. I think what has become clear that sofriba, so not having 2 DAAs, is a problem in some patient group with type 2 and 3.
Yeah, and I think this is illustrated on other presentations that are seen here. So this is another real-world cohort, which is from Spain, and only with the 3D regimen, the AbbVie 3D regimen. And this slide shows that the vast majority of patients achieved SVR. That was true for genotype 1A and genotype 1B patients. And also true for patients with cirrhosis. 97% of patients with cirrhosis achieved SVR. And in that study, they had Child-Pugh A and Child-Pugh B cirrhotic patients. We learned lately that this combination should not be used with Child-Pugh B patients with decompensated cirrhosis because of the protease inhibitor. And there have been cases of decompensation, but I think the results in patients with compensated disease are very excellent and can be used very safely.
Also in the prospective trial where 3D was evaluated in Child B, the response rate was 100%, but there is the issue of side effects and increase in bilirubin.
Yeah, we have to be careful. And also something we learned at this meeting that patients who have compensated disease but a history of decompensation in the past should not receive a treatment regimen based on a protease inhibitor.
Yes, because we have safer alternatives.
We have alternatives. Yeah. So the second group of presentations that were made and important were on special populations. Number one, in patients with advanced fibrosis. We alluded to these patients already. And this is an Italian study where different regimens were used in patients with genotype 1 infection and advanced fibrosis. And this shows an overall SVR rate of 94%. As you said before, sofosbuvir ribavirin is not a good option. I was surprised that the results were not that bad, but it should not be used. We should use a better combination. And this slide shows in patients with advanced fibrosis that 94% of patients achieve SVR with sofosbuvir, cimeprevir, 93% with sofosbuvir, adipasvir, and 98% with the 3D combination. So these work very well in patients with advanced fibrosis. And there was another Spanish real-world study in a pretty large number of patients. They had more than 800 patients, showing that SVR rates can be very high in the real life in patients with Child-Pugh A compensated cirrhosis, 94%, but the SVR rates in the real life are lower for patients with Child-Pugh B and C, 78%. If we think about what they were a few years ago when we had nothing virtually. Interferon was contraindicated in these patients. It's outstandingly good, but we still have progress to make in this group of Child-Pugh B and C patients to try to improve the SVR rates.
Yeah, I agree. It's very difficult to reach more than 90% cure rate in this decompensated disease. But I said it had convincingly shown that adding ribavirin from a antiviral perspective or to increase the sustained response rate is important, but of course there's a safety issue also. But extending treatment duration without adding ribavirin was less effective.
It was less effective, so ribavirin is still a very useful drug.
It's useful, and I think we can probably also discuss later whether in these special population also baseline resistant
we'll discuss that.
Might be meaningful.
So there were also some presentations on clinical endpoints, and especially a real-world UK presentation in patients with advanced cirrhosis that clearly demonstrated that patients who are treated with an SVR have a much better prognosis, a much better survival 15 months after treatment than patients who have been treated but were not able to achieve an SVR, and patients who were not treated. And I think this is a very clear demonstration that you can really improve the clinical outcome of the patients when you treat them and you cure infection in these patients with severe forms of cirrhosis. And this is probably something very important. However, in this same study, it was very clearly shown that the patients who benefit more are the ones who have a less severe disease. And there was a difference in terms of adverse event-free survival at 15 months between patients with a very high MEL score, above 15, compared to patients with less than 15. And also when they compared Child-Pugh A and Child-Pugh B patients, they had a very good clinical outcome. And the outcome was very poor in patients with Child-Pugh C cirrhosis. And this tells us that maybe Child-Pugh C patient, even if you're able to cure infection, will not really benefit from this cure because their disease is too advanced and they will have the complications of the disease anyway.
Yeah, I think this is really a very important study, and the beauty of this study is that for the first time, although it's not a controlled trial, we have a matched untreated cohort and clearly shown the difference. And it also raises the question of the point of no return. And I think from more data, it may become clear that Child-Pugh-C with a MELD score above 15 or 18, it's a little bit a debate where the best cutoff is, but then that we will not really change the course of the disease, even when we are able to eradicate the viral
And we have other options. They can be transplanted and treated after transplantation, and we know that treatment works very well after transplantation. So probably the virus is not the emergency there.
Yeah.
So there were other groups that were presented that for which we didn't have any information about the efficacy of the new HCV drugs, and especially a study in kidney transplant recipients, which are an important population. Many of them are HCV infected, and that study was done with sofosbuvir and ledipasvir for 12 or 24 weeks, and the SVR results were excellent. Overall, all patients with 12 weeks and 96% of patients with 24 weeks, but the failures were 2 patients who were lost to follow-up. All of them responded to therapy, so very good results. And this study included patients with genotype 1 and a few patients with genotype 4 infection. So I think we now have a good option for patients who are kidney transplant recipients. That was a demand from the nephrologists to have access to this kind of treatment. There was no reason why this wouldn't work, but I think this study is very helpful and will be used to help these people to be treated in the post-kidney transplant setting. Another interesting study is treatment of adolescents. There were only studies in adult patients, and these studies showed good results, but we didn't know how to treat children or adolescents. That study was presented with adolescents infected with genotype 1. It was done with ledipasvir and sofosbuvir given for 12 weeks. And again, there was a very high SVR rate. It's 97%, but the 3 patients did not achieve SVR were lost to follow-up. So it's not virologic failure. We can consider that the modified ITT would be 100%, so the per protocol would be 100%. And this was very efficacious both in treatment-naive patients with or without cirrhosis, and in treatment-experienced patients. They didn't have any patient with cirrhosis in the treatment experience. Few patients had cirrhosis, by the way, because adolescents generally have a mild disease. But I think we can safely use this combination in younger patients than the ones who were exposed so far.
Yeah. I think a very important message that it's also safe and quite effective in the adolescents.
Yeah. And we had a problem before with using peg-interferon ribavirin in this group of patients, in children and adolescents. Currently, we can use this combination of sofosbuvir and ledipasvir safely. So I think this is a very important message. The last special population I wanted to discuss is a population of acute hepatitis C. There have been discrepant results in the literature about treatment of acute hepatitis C with different types of regimens. Generally suboptimal regimens such as sofosbuvir, ribavirin. Here, this is a combination of sofosbuvir and ledipasvir that was given for 6 weeks in 20 patients infected with genotype 1. And to make it short, all patients responded. They responded on treatment. They achieved an SVR. So they appear to be a relatively easy to cure population, but this just tells us that we should treat patients with acute hepatitis C with the interferon-free regimen, and we can expect to achieve very high rates of SVR. The question of the duration is still there. What is the best duration? What do you think?
Well, 6 weeks worked in 100%, so there's probably space also to shorten treatment duration for probably 4 weeks if you start quite early. Always there's a question because a certain percentage of these patients will eradicate the virus spontaneously, whether you have some of predictors to wait, let's say, for 4, 6, 8 weeks to see whether there's spontaneous clearance and start afterwards. On the other hand, we know that some of these patients have risk factors for viral transmission, and from an epidemiology point of view, it would make sense to treat as early to prevent transmission. I think if data confirmed, why not starting immediately with treatment? And I think a good argument could be that it was shown that also clinically, these patients clearly improved.
Yeah.
They were jaundiced,
Yeah.
at high levels, were tired, and bilirubin went down
They
quite
cured,
rapidly.
that's good.
Yeah. So also from the quality of life aspect, it would make a difference.
Obviously, where we may have problems is when we treat patients with acute hepatitis C who are using drugs, and the risk of reinfection can be there, and we'll have to be careful with that. So the other topic I wanted to discuss is HIV resistance. We introduced a new terminology because RAV is something which is not accurate and has been used to define two different entities: the virus that is resistant and the amino acid change that confers resistance. So the proposal will be to say that the virus is a resistant variant, the virus is resistant, and that the amino acid change that causes resistance is a resistance-associated substitution, RAS. This allowed our American friends to make a few jokes on RAS, RASes, whatever, but I think it will be helpful because it's important that people understand exactly what they're speaking about and understand the mechanisms behind this. So there have been a few presentations of real-life data from the US, from Europe, Germany, and other countries. And I've taken this prevalence of NS5A RAS in the general population, general treated population in the United States, showing in genotype 1A patients and in genotype 1B patients what the proportion of patients had detectable RAS at baseline. And you see that the 1A patients essentially had mutations at position 28 or 30 and 93, and the 1B patients had more frequent RAS detected at position 31 and 93. But overall, the sum was that 12 to 17% of patients had detectable RAS. And we know from other studies that were presented at other meetings that the presence of RAS at baseline may have an impact on the SVR. However, this impact is not in everybody. It's essentially in patients who have other factors of non-response, genotype 1A patients, cirrhotic patients, patients who were treatment experienced, failed a peg interferon ribavirin regimen, essentially.
Yeah. So this is a concept that you need additional stress factors. And for me at the moment, looking at all these data, I think that there's a rationale to look for baseline resistant variants in genotype 3 with cirrhosis, pre-treated especially, but with interferon, not with DAA, and in the decompensated disease. And probably here with the current drugs, the impact of the resistant variants is there, and you may choose a different regimen according to your baseline resistance. So if you have easy access, I think these were the two patient population I would
I would agree because these patients generally go to expert centers that have access, but the vast majority of people, and especially those who are watching us, do not have access to resistant testing. And I think we can agree that you don't need to do resistant testing first line systematically, except in very specific groups of patients who generally are taken care of in tertiary referral centers. And this is what we're doing in our place. So we were surprised that in the same study, they looked at the impact of the presence of RAS at baseline on SVR and didn't find a great impact. Actually, the SVR rates with different regimens are shown here in blue in patients without the RAS, and in red in those with the RAS, and there was no difference. There was a bias in that study that is a real-world study that in the United States, they have a broader access to HIV-resistant testing, and probably the prescription was influenced by the result of HIV-resistant testing. So at the end, you have no effect just because the treatment was tailored to the HIV resistance test. So this is what there was, but if you look carefully at the clinical trial data, you see that the presence of RAS has an impact in these subgroups of patients we mentioned. This is not the case in patients who received a 3D regimen, and this was confirmed here in a study showing that the presence of NS5A RAS at baseline did not have an impact on the results of the Ombitavir, Paritaprevir, the Sabuvir combination. And the reason is that this treatment is already optimized to prevent the effect of RAS because all genotype 1A patients receive ribavirin, 12 weeks or 24 weeks when they have cirrhosis. And this explained that this is over-treatment for some patients, but covers the effect of RAS, which is not always the case with other regimens. And I think the message is that if you have a patient who have, as you say, stress factors such as cirrhosis, prior experience, genotype 1A, all three, adding ribavirin may prevent the effect of potential RAS, even if you are not looking for them on SVR for 12 weeks of therapy. There was another study which I found intriguing. It's a summary of the resistance data in the SOLAR-1 and SOLAR-2 studies, which were done in patients with advanced liver disease and post-transplant. And the message in these studies was that, number one, ribavirin was needed, but number two, 12 weeks and 24 weeks didn't make a difference. But here they showed the results according to the presence at baseline of NS5A RAS. And it's visible that in the group of patients who had 12 weeks of sofosbuvir, ledipasvir plus ribavirin, the patients who had no RAS at baseline had a 100% SVR rate, whereas 3 out of 13 patients in the group with RAS failed. And in the group of patients who received 24 weeks of treatment, everybody achieved SVR. It's very small numbers, so it's very difficult to conclude, but there may be a signal here that in patients with advanced liver disease or post-transplant, with NS5A RAS, if you can detect them, a longer duration of treatment, 24 weeks, might be helpful.
Completely agree that it's what we have mentioned earlier, is it the matter of these stress factors, and if you have quite unfavorable predictors, extending treatment duration plus adding ribavirin is the best solution.
Yeah, we want to cure these patients. They are the most difficult to cure. So just to finish, there were also some presentations on the next generation of HCV drugs, and there are essentially 3. The second generation IV combination, the triplet from Gilead, and the microRNA 122 antagonist. So speaking about the second generation IV combination, it's a combination of a second generation NS3 protease inhibitor, ABT493, and a second generation NS5A inhibitor, ABT530, which are pangenotypic and have good activity against viruses that are resistant to the prior generation. And there were 2 studies presented in genotype 3 patients, phase 2 studies with outstanding results. 100% SVR rate if you remove the non-virologic failures, 97% ITT in non-cirrhotic patients, and 100% SVR rate in patients with genotype 3 cirrhosis. And I think this is really important because patients with genotype 3 who have cirrhosis currently are the most difficult to cure patients. They still raise issues. And in that study with this combination, apparently the results were very good. We have to wait for the phase 3 trials, which are ongoing. But this combination could be the best option for genotype 3 patients.
Yeah, very good news. And also, I'm not sure whether you will show the data that this combination also works for NS5A resistant variants. So if patients do not have a very advanced disease, they may wait for these new compounds.
I'm showing this data. This is a study where the same combination was used in genotype 1 patients who previously failed a DA-based regimen. And there were people who had NS5A substitutions, others who had protease inhibitor, different kinds of exposures. And the SVR rates with different doses of the drug and with the highest dose were extremely high, between 95% and 100%. So you can also retreat patients who failed a prior DA regimen with this combination of ABT493 plus ABT530. So this looks like something that will be competitive in the future. The other interesting data was shown with the triple combination of sofosbuvir, velpatasvir, the new NS5A inhibitor that should be on the market in Europe this year, plus another drug, a second generation protease inhibitor, GS9857. And this was used in treatment experienced patients, including patients who were DAA experienced, also patients who had been exposed to DAAs and developed resistance. And the SVR rates were very good, 100% in genotype 1A patients, 100% in genotype 2, 97%, only 1 patient failed in genotype 3, and 100% in genotype 4 and 6. So this is also a very promising combination. Will it be used first line or will it be used as a rescue therapy? This we'll have to discuss, but it will obviously probably depend on pricing and availability, treatment duration.
So but probably treatment can shorten considerably.
But we have good options for the future. The last one I wanted to show, which is intriguing, is RG101. RG101 is a microRNA 122 antagonist. It's an injectable drug. You do it intravenously, so it's not easy. But the good news is that you give one injection, a second injection 1 month later, and they didn't give it alone. It would have been interesting to see it alone or with ribavirin. It was combined for 4 weeks with DAAs, the dipasvir, sofosbuvir, in one group, cimeprevir in another group, and the clatesvir in the third group. And what appeared is that there was a sustained virologic response. 4 weeks of treatment, one injection at the beginning, one injection 4 weeks later, the DAA, and the patient's cured infection. So it's very spectacular. The mechanism that they block microRNA 122, which is a hepatocyte component that is important in the replication of HCV. Is there a future for this? I would tend to think that that would be a great rescue treatment for patients who fail other regimens. Is it a good first-line therapy? Not sure. It's injectable. It raises issues. What is the long-term side effect profile? Because you change something in the liver, we don't know. But at least I think it's an interesting concept that can be applied to other infections and also other diseases, that by antagonizing a microRNA, you may have a medical effect on something. And I found this very interesting.
Yeah, I agree. I think the most important thing here is really long-term safety and what will happen if you target the microRNA. But the concept is really fascinating. Yeah.
So this is the end of our presentation, discussion of the viral hepatitis presentation, the ILC2016. We would just like to remind you that in September 23rd to 24th, there will be a special conference organized by EASL with the support of AASLD in Paris, France, on new perspectives in hepatitis C virus infection, the roadmap for cure. And we'll take the opportunity of that conference to launch the new EASL recommendations for treatment of hepatitis C on the 22nd of September. I will start at 5:30 in the evening with a presentation, and the guidelines will be published that day. And on this, I would like to thank Thomas Berg and thank EASL for an outstanding meeting and giving us the opportunity to debrief on the viral hepatitis data. Thank you very much.
Thank you very much.